All right, thank you very much, and thanks again, Frank, for the opportunity to participate in this wonderful meeting. These are my disclosures. I am PI for Roadster 3, but I'm not taking any personal income, so these are my opinions. But it's all based on a lot of data, and I think Mahmoud has already shown some of that, but I'm going to focus in on some more recent data comparing transfemoral stenting and TCAR. First, I think Mahmoud had shown this. But looking at 30-day stroke death MI plus ipsilateral stroke out to a year with TCAR was 5%, and it was almost 10% with transfemoral stenting, highly significant. What's happened with TCAR and transfemoral stenting in the VQI? You can see TCAR on the rise. Transfemoral had plateaued, but we merged with NCDR in 21, so that's why we have an increase here. So now we have a lot of cardiologists doing transfemoral stenting in the VQI. So brand new data now in VQI, TCAR surveillance project. Yes, it's self-reported, and so if we had a neurologist evaluating every patient, I'm sure the rates would be higher. But there's no reason to suspect that they're differentially under or over-reporting for one procedure versus another. And so, yeah, we're probably missing some minor strokes, so most of these are going to be more major strokes. So we've got almost 45,000 TCARs, almost 25,000 transfemoral stents, and with the VQI, our best endpoint is in-hospital stroke or death, and so that's what we focused on. But because of that, we determined that an appropriate threshold where patients still get benefit would be a 2% rate for asymptomatic patients instead of 3%, and 4% for symptomatic patients instead of 6%, and that's because we and others, as Chris mentioned, a lot of strokes and deaths within 30 days occur after discharge. So you really need to be below those numbers to have acceptable rates. And we use propensity score methods to deal with any potential patient differences, but these groups are actually quite similar. So what is it with 45,000 and 25,000? Stroke or death 1.6 versus 3.2, relative risk of 2, stroke also significantly different, death, MI exactly the same, and yes, cranial nerve injury is significantly higher, but 0.3 versus 0.0. I'll let you determine the clinical significance of that. Now, breaking it down into numbers that make more sense, that we can wrap our heads around, in symptomatic patients, nowhere near that 4% threshold of acceptability. TCAR is highly significant, again, for stroke, and death. MI was actually lower in TCAR in this group. In asymptomatic patients, not below the 2% threshold for transfemoral stenting, significantly lower. In TCAR, lower stroke, lower death, same rate of MI. How about the learning curve? With TCAR, these are the real first 5 cases of operators in the US. 1.5. Did it get better as we got more expertise? No different. The only clinical outcome that changed with experience was bleeding complications because we started using more protamine. Now, more data from the VQI, and this isn't even really the learning curve because most people had done carotid stents before joining VQI. But in symptomatic patients, to get down to that 4% range, you needed to do 235 cases, and you never get down to where TCAR is. Asymptomatic patients, to get to the 2%, it's only 13 cases, but if you want to get down to where TCAR is, you need to do over 400. Protamine is safe and effective, and centers that adopt TCAR drop their MACE rates by 10% after a year, compared to if they had continued to only provide CEA. And this was supposed to be a slide showing transfemoral and transbrachial, but basically, transbrachial was statistically similar to transfemoral, but numerically worse, and it was statistically worse than TCAR. So transbrachial is not the way to fix all the problems for transfemoral stenting. So in summary, TCAR has a lower rate of stroke or death in both symptomatic and asymptomatic patients. It has a far shorter learning curve. It's a procedure for the masses, not the select few like we're hearing about the transfemoral trials, where you have to have done hundreds to be selected as an investigator. And adding TCAR improves overall carotid outcomes for all institutions. Thank you very much.